Welcome to my presentation. I'm pleased to be able to share with you all my thesis, titled Standard Reference Values for Musculoskeletal Ultrasound of the Posterior Tibial Tendon. In the last few months, I have spent so many hours sitting behind my laptop that it eventually gave me back pain. I really should have known better as an almost graduated physical therapist, but I was passionate about what I was working toward, and I would not change a thing, except perhaps the amount of ergonomic support involved. Today I hope I can inspire you with the knowledge I have gained. But first, I would like to introduce you to Ben. Ben is 30 years old, works in ICT, a little bit on the chubby side, and he just started to run. But what would you do if he came to your clinic with complaints of burning pain and numbness affecting the plantar aspect of his right foot? I might suspect tarsal tunnel syndrome, palpate the area, perform a few clinical tests to differentiate between some early diagnoses. The less than desirable diagnostic accuracy of these tests means that even after a rough examination, I'm still uncertain about the actual condition with which Ben has presented. This scenario is all too common among physiotherapists, and to combat it, musculoskeletal ultrasound is being used increasingly as an extension of the physical exam to provide real-time information on the level of body functions and structures. Tendons in particular are very suitable for ultrasound examination due to their high contrast with the surrounding tissue. But anyway, back to Ben. In his case, I chose dynamic ultrasound scanning to visualize the tarsal tunnel and get a better insight of his problem. What I found was thickening and inflammation around his posterior tibial tendon. Posterior tibial tendon dysfunction can be a primary reason behind tarsal tunnel syndrome. In the initial stages of posterior tibial tendon dysfunction, the tendon becomes thick and shows hypoechoic, which is dark, on the ultrasound beam, as you can see on the picture on the slide. This is in contrast with the usual hyperechoic tendon, which is white. Progressively, the tendon becomes thin and loses its biomechanical possessions. So for further investigation of Ben's tendon, I paused the screen in order to measure the thickness and the cross-sectional area of his tendon. For accurate and correct diagnosis of posterior tibial tendon dysfunction, these values should be compared to standard reference values. But how do I know what's normal? This has resulted in the following research question. What are the standard reference values for musculoskeletal ultrasound of the cross-sectional area and the thickness of the posterior tibial tendon? As you can imagine, Ben's tendon is probably bigger than the tendon of a 12-year-old girl. Also, earlier research describes the influence of several variables on lower leg tendon morphometry. This has resulted in the following research question. What is the influence of age, gender, height, weight, BMI, flat foot deformity, running activity, and side dominance on these values? To find an answer to these questions, two other students and I recruited 128 participants, which of 75 female and 53 male. The mean age of our participants was 23.5, since we only recruited healthy participants in the age of 18 between 40. As Marissa told us before, ultrasound scanning is very user-dependent, and therefore we standardized measurements by using the radiology guidelines for the ankle of Europe. As a reference point, we used the middle of the medial malleolus for transducer placement. Ultrasound scanning is not easy and requires a lot of practice. To give you a better insight in how ultrasound works, I will use my own wrist and carpal tunnel as an example. The transducer must be placed in a 90-degree angle to the structures, which we call perpendicular, by all times. When the transducer is placed perpendicular to the orientation of the tendon vesicles, they will appear bright and reflective. But when the transducer is just slightly turned, this hypoechogenic appearance is lost, and you might even see anisotrophy, or things that are actually not there. This has a very bad influence on the diagnostic value of ultrasound. In our research, we made 2 transverse, like this, and 2 longitudinal images of the posterior tibial tendon on each side. On the pictures on the slide, you see on the left a transverse image of the posterior tibial tendon, and on the right a longitudinal image. We made 24 images of the participants, and in the total research we made over 3,000 images. To explain the results of my research, I will take you back to Ben. In the upper table you can see the thickness and cross-sectional area values that I found for Ben's tendon. If we want to compare these values to the standard reference values that I defined, we have to acknowledge the influence of the variables gender, height, weight, and BMI, as these showed significance in regression and ANOVA analysis. Regression showed that cross-sectional area is clearly greater in male and differed in left and right. Increased thickness of the tendon is associated with male gender, higher values of BMI, and greater body height. So if we now go back to the values of Ben, we see that his cross-sectional area on the left side was 31.6. In comparing to the standard reference values that I found for male gender, which were 30.2 on the left side, we see a slight increase. However, this increase could be explained by his above average height, weight, and BMI. If we now take a look at his right cross-sectional area values, which was 50.9, in comparing to 29.7 in my group, we see an increase that cannot be explained based on the standard reference values, neither by the predictor variables. And this suggests tendon pathology. For further investigation, we can have a look at the thickness values of his right cross-section of his right tendon, which was 5.3, in comparing to 3.6 in my research group. Again, we see an increase that is abnormal, and this suggests pathology. So based on the outcomes of my research and the standard reference values, we can now with certainty say that Ben has posterior tibial tendon dysfunction on the right side. I hope this example has given you a better insight in both the use of musculoskeletal ultrasound as the overall aim of my research. I would like to end with a quotation of the founder of modern human anatomy, who in the 16th century remarked, "I am not accustomed to saying anything with certainty after only just 1 or 2 observations." Indeed, high levels of data need to be collected in order to make certain conclusions. And thus, scientific research in the field of musculoskeletal ultrasound must continue. Thank you all for listening to my presentation, and if you have any questions about the results or the statistical analysis, please feel free to ask. Thank you.